morning, and welcome to our special session of the EHE Regional Learning Collaborative on the Integrated Statewide Strategic Plan and EHE, which is hosted in collaboration today with the California Department of Public Health. My name is Elena Rosenberg-Carlson, and I'm the EHE coordinator here at the UCLA Center for HIV Identification, Prevention, and Treatment Services, or CHIPTS. For anyone who might be new to the collaborative, this all started with an in-person meeting that we hosted here in Los Angeles in partnership with the Office of AIDS back in early 2020 to help launch a regionally coordinated response to ending the HIV epidemic across our 8 EHE Phase 1 counties here in California. From that, this learning collaborative was launched to facilitate knowledge sharing and support collective action across our 8 EHE Phase 1 counties to help accomplish our shared EHE goals. And today is very exciting because we're going to be talking about this new statewide integrated strategic plan and how it aligns with EHE plans and how we can all work together to move our collective efforts to end the HIV epidemic forward. As always, we do welcome folks from outside our 8 EHE Phase 1 counties to join the sessions and learn together with us, and it's great to see all of you on the call today. In the chat, you should see an option to send a message to everyone. If you haven't yet, please do use that option now to introduce yourself to everyone on the call by sharing your name, affiliation, and location. Next slide, please. All right, so we have several different folks on the line with us for today's session, which is why we have an extended 2-hour session today. We're going to be doing an overview and process update to start. We're going to then move into a set of panel presentations, and then we'll have some additional panel discussion and Q&A with all of our presenters and panelists at the end. You can enter your questions using the Q&A function on your Zoom control panel. And if you have any comments or resources you want to share with everyone on the call throughout, feel free to use the chat function for that. I also want to note that we are recording the session and we'll post the recording and slides on our EHE Regional Response webpage within the next week. So now we'll get started with Leroy Blea, who is the Ending the Epidemics Project Manager at the California Department of Public Health Office of AIDS. Thanks for joining us, Leroy.
Good morning, and I'm just going to go ahead and share my slide deck. All right. Thank you so much, Elena. And I'm just going to actually move us all around so that I have access to my notes. Thank you for that introduction. My name is Leroy Blea. I use he, him, and his pronouns. And it's a pleasure to provide an update on our strategic plan and our next steps. I just want to make a note before I start that this is that my slides actually represent the work of many, many people. And I wanted to especially call out the leadership of Dr. Marissa Ramos and Dr. Kathy Jacobson, who spearheaded the development and rollout of this plan, along with many other partners. I also want to thank this regional coalition for allowing us to actually provide an update here. Elena, you and this collaborative have been instrumental in providing some regional solutions for our EHE work. I want to thank Vicente Consulting, who were the primary architects of our planning process, particularly our community engagement process that was large and extensive as part of our rollout of this plan. And of course, the ETE coalition that's represented on this panel. Their work informed and actually influenced the state to have a plan that focuses on syndemic work through social determinants of health. So it helped the work overall of the ETE coalition over the years that it's been in operation has changed the way that we address HIV work in California, and we continue to partner with them. We'd like to thank our co-author health jurisdictions. Most of our Part A jurisdictions have joined us in co-authorship of this plan, and today they're represented by San Francisco County and San Diego County that are going to be talking a little bit about how they are referencing our plan and using it to help organize their work locally. Next slide. I have a brief process update that will include just a review of some of the things that we've done in the past about community engagement and some of the things that we're going to be doing in the future. And we're going to be asking for your help a little bit on perhaps informing and giving us some suggestions for some of the things that we might have forgotten about or overlooked in our community engagement process. We'll be talking about our implementation blueprint that was developed over the last year. We are just about ready to release it, so I can't show it to you exactly today, but it's going to be released soon. I'll be talking about the next steps for that. I'll be talking about the strengths and challenges of our process, and then some ways that you can become involved in the process going forward over the next year. So first, to just review, we have, as you all know, HRSA, HAB, and the CDC require that those of us that receive federal funds for HIV prevention, care, and treatment have an integrated plan that is focused on HIV prevention, that integrates HIV prevention, care, and treatment. And because California and many other jurisdictions have been doing a lot of planning over the last 10 years, really, including our efforts to address the Ending the Epidemic initiative, we have been allowed to level up. And California has taken that opportunity to address HIV not only as a condition on its own, but as a syndemic with hepatitis C and other STIs. So we have submitted our integrated plan that addresses the syndemic to HRSA, HAB, and CDC as our required plan. And some of our initial comments back from that review process have been very positive. So HRSA, HAB, and the CDC are excited that California has really incorporated some of the recommendations also of national strategies, the strategic plan nationally to integrate syndemic work as part of addressing HIV work. We have an accompanying document that you've actually seen this plan. This is the yellow plan, but our accompanying document I'll show the cover of that helps us delve into and make more specific the strategies that I'll show you on the next slide. I'm not going to detail the contents of our strategic plan that is online. We have a specific website that's set up for our strategic plan, but really as a high-level overview here, this just gives the sense of the social determinants of health that we selected to focus on in the plan. And we selected these social determinants of health with the help of many experts that were both content experts and community experts to develop our a plan that was supposed to be accessible. So it's shorter than many of our previous plans. It's about 24 pages long. And this gives a high-level overview of the 6 social determinants of health with the strategies that are located under each of these, including racial equity, housing first, mental health and substance use, economic justice, stigma-free. Just a quick review, this was released in January of last year. And over the course of the year, we engaged in a large community engagement effort to get input and specific recommendations about how we make all of these 30 strategies real. And that is what's contained in our implementation blueprint. And our co-author counties, I'll just read the entire list, which we're very excited to share co-authorship with Alameda, Contra Costa County, Sacramento County, San Bernardino and Riverside counties, San Diego, San Francisco, and Santa Clara counties. So we know that there are a few other integrated plans in operation in California, and we're thankful to Los Angeles County and Orange County for sharing their plans with us and helping coordinate these efforts, their efforts with us over the next 5 years. Our process of community engagement, as I said, developed a implementation blueprint. And I'll be talking a little bit about that in a few slides. But before that, I'll just mention that our efforts to develop our plan and our implementation blueprint, because of what we're doing to address social determinants of health, will of course involve strategy partners that are located outside of the Department of Public Health. So we're excited to include just a list of strategy partners here that when you see the implementation blueprint will be named in the plan for specific activities. So we know that if we want to address housing first and think about housing as healthcare, that we need to connect and link with departments with departments like the Department of Social Services that has more specific interventions focused on housing. So we're excited to partner with these strategy entities and to connect to them as part of the implementation of our strategic plan over the next 5 years. We talking about the community engagement that we had as a result of our kickoff at the beginning of last year. We're very grateful to our Part A planning bodies, and which include the statewide CPG group, the Inland Empire Planning Council, LA's HIV Commission, the Alameda County Oakland TGA, Sacramento County's HIV planning group, and as well as San Francisco and Santa Clara's HIV commissions. We're excited to continue in another round of outreach to them, and but we also had, as part of our community engagement, a statewide town hall kickoff meeting that included over 460 participants. We had 17 in-person meetings throughout 5 regions of California that included 4 virtual meetings, including meetings in Spanish, that reached over 300 participants. We had a virtual input survey because all of this work took place in the concurrently with COVID as well as MPOX, and so it was difficult during COVID to do all of the in-person outreach that and community engagement that we wanted to, but we certainly were able to reach many more people through virtual means, which all of us have become more expert in that, as evidenced by this regional session today online. We had a provider needs assessment as well as a virtual survey that we released, and we had over 130 respondents from 27 counties throughout California. So as a result of all of that input from many stakeholders across California, we developed an implementation blueprint, and that was released to a community comment period in December of 2022. And we're taking that information, incorporated into some specific changes, and finalizing that plan in March. And so we plan to release that implementation blueprint to you all again as a final version of it in March, and we're very excited to be able to do that. When that does happen, we're going to have a second round of presentations to planning councils and have some specific strategy sessions. And I'll describe what those strategy sessions are going to be all about, but they're about customizing our implementation blueprint for use for local communities. And then we have some special kickoff meetings, particularly in our co-author counties, to help just start off conversations with some support from Vicente and also the Office of AIDS as part of the process of rolling out our implementation blueprint for each one of our jurisdictions across California. So what is the implementation blueprint? Those of you that have seen it and been able to provide input to it for our community comment document that was released via the website that we set up for this will know that this implementation blueprint was once again organized with our 6 selected social determinants of health in mind. We have 30 strategies under each of those 6 social determinants of health, and under each one of those strategies, we have recommended activities, and there are a lot. We have about 150 activities, and I say 150 plus because in our final version, some of our activities may be combined. So I won't give you an exact number, but it's approximately 150 activities that are recommendations. They're not mandates, but they are the best recommendations of community members and stakeholders across the state for us to be able to make progress to address this endemic through a social determinants of health lens. So there'll be some steps involved in actually making those activities more relevant and connect to local work. And I'll be talking about that in a slide a little bit later on. But I want to suggest to you that the implementation blueprint also has some resources and the collective wisdom of all the individuals that came and participated in our community engagement process. These were distilled as overall considerations for developing and implementing the plan. These are in sections in each one of for each one of the activities. There are local considerations, so special notes for a session that we might have had in Sacramento County. We'll have special notes for Sacramento County in particular. We have key population notes so that if we want to address issues for cisgender women or women that can, or cisgender women or people that can become pregnant, we have special considerations for that population that are noted when it was noted by community members that were part of our listening sessions. We have monitoring and metrics. So we are starting out monitoring overall our plan with some traditional metrics that we used from our last integrated plan. We have a crosswalk of those metrics that are mostly developed and derived from our surveillance data. But we know that we're probably going to need to develop additional metrics. So if we want to measure the impact of racism, for example, or how we're doing with regard to developing and building racial equity, we'll probably need more in different types of indicators. So that is built into the process of what we're doing in this first year of the plan. We also have a section of partners and resources that suggest what ways that you can leverage existing resources and partnerships that already exist in different parts of California for the activities that we name. So some exciting things that are included in implementation blueprint. It is not as short as the original plan. It's about 84 pages long, but we know that some of our jurisdictions that are co-authors are planning to take our implementation blueprint and use it very specifically to enhance the work that they're doing locally. For example, Santa Clara County will be starting with their Housing First section and working with their local planning council, or HIV Commission rather, over the next year to fill out and to organize their work more specifically for Santa Clara within the Housing First section of the plan. And Housing First section of the plan really addresses how we make housing really an outcome of healthcare, and vice versa, how healthcare can be something that impacts housing. And there are specific activities and suggested ways to do that are part of our implementation blueprint. Some of our next steps for implementing our plan include, well, we want to release it in March. And so we're excited to be able to do that. We're going to be doing that with some through a couple different methods. We have, we can release things through our OA voice. We're going to be doing a press release about it. We're going to get it through to as many stakeholders as possible. And we invite you when it is released to distribute that widely throughout your networks, because we know that you're helping us out in providing more connection to this integrated plan. And, I'll be talking about this well, let me talk about it on this slide. We're also going to be doing some Part A, another round of Part A Planning Commission meetings. So planning councils and our HIV commissions are one of the engines that drove input to this and are providing oversight to our integrated plan. So we're going to connect to those bodies and the consumers and the stakeholders that are part of that again and again as part of this process and the oversight of how we're implementing our strategic plan. We plan to also have some strategic planning sessions that are going to look, well, they're going to answer the question about as to how to customize our implementation blueprint for local efforts. So we know that jurisdictions like San Francisco and San Diego have a body of work that they'll be talking about today that really predates this plan and informs this plan in many ways in the way that they've been doing Getting to Zero and EHE work. Though their plans are cited in our strategic plan that we submitted to the CDC, HRSA, and HAB. But we're thinking that each one of our jurisdictions, no matter where they're at and the level of resources that they have to implement this plan, will go through a process of aligning and taking and leveraging local efforts. So some things that are located in the plan may be more relevant to some jurisdictions than others. And as a result, there'll be some type of prioritization and scoping and feasibility that happens with each one of the activities locally, that there'll probably be some type of home within local jurisdictions for each activity that does get implemented locally. We're going to mirror that process with at the state level. We have about 45 of the activities that name CDPH as the main stakeholder and overseer of and shepherd of the activity. And so we're going to take responsibility and have homes within the STD control branch and within within the STD control branch and the Office of AIDS to shepherd activities that specifically name the California Department of Public Health as the person that is to oversee this activity. We also are going to provide some assistance with developing a communications plan locally, and then developing new collaborations and partnerships as part of your implementing our implementation blueprint. And then, of course, we'll be talking about indicators and monitoring. As I noted, we're going to be suggesting that you have a list of local indicators that you follow. We're going to be developing a statewide list of indicators, and we're asking that each one of our jurisdictions that develops a plan associated with this implementation blueprint submits this plan to the Office of AIDS and the STD control branch. We can take responsibility for overseeing that work plan at a state level. So that's just a suggestion. We're not mandating that. So this is our roadshow, our initial set of education about the plan. We're beginning this with a kickoff meeting today as part of the regional collaborative. So we're really excited to be here today. We're going to be doing some presentations at the California Planning Group, as I said, Part A Planning Councils. CDC and HRSA is planning a kind of the California tour in the summer of this, late summer of this year, and we're going to be integrating our strategic plan as part of that process and making it relevant to our baseline prevention activities as they're being implemented across the state. We also are going to be, we plan to make multiple presentations at the STD and HIV controllers meetings. We have an annual EHE and Strategic Plan Symposium that's planned for the end of June, where we'll be going to be talking about progress and having some workshops, some specific things related to sub-activities that are part of the plan. So it'll be an opportunity for people to hear more about what's going on within the implementation blueprint within certain jurisdictions. And we also want to hear from you. What is missing in our initial education and rollout of this plan? If you have suggestions about places we should be, places we should do a presentation, I'd love to hear it. I'm happy to participate in in any group that will invite us. We'd love to talk more about this plan to you, to your constituencies and stakeholders, and make this real and more accessible to organizations that would want to take this into their planning efforts. I have just a few minutes left, so in that, I'm going to just note that there were some strengths and challenges to the way that we rolled this out over the last year. I'm going to just highlight the fact that this is a community plan that was driven by community input, and we have plans to incorporate community again and again and again in its implementation as well. So that's a strength. We love the fact that we have counties that have decided to co-author this plan with us, and then we have local community champions that helped all along the way with developing our community engagement strategy. Challenges continue to be COVID and other conditions like MPOX that have siphoned away some of our resources to deal with emergency issues, and we're really looking forward to getting back some of those resources and focus so that we can think about proactively doing public health rather than an emergency framework. And resources are always an issue. We know that this is a tough time resource-wise for not only the federal government, but also the state of California. And so we're going to be looking and having some conversations about what about resources might make most sense in the way that we synergistically roll this out across the state. Communication is going to be key. So to end, I'm just going to suggest that I'm going to turn this over to my colleague at the STD Control Branch soon, but I'm going to just a plug. If you have any questions or want to get involved, you can email me. You can also email the general mailbox of the Office of AIDS. We also have a website that's set up to communicate specifically about our integrated plan. You can link to our plan, the eventual implementation blueprint, and also some of the past sessions that we've had that are recorded and are available to you so that you can review some of the basics of the plan at your own pace asynchronously. So with that, I'm going to stop sharing, and I'm going to invite my colleague, Ashley Doctor, to talk about how some of the STD Control Branch initiatives that are aligned with the plan and how we are working together to roll this out across the state. Ashley, over to you.
Thank you so much for that kind introduction, Leroy. As Leroy shared, my name is Ashley Doctor. I'm the Evaluation and Quality Improvement Unit Chief with the STD Control Branch of the California Department of Public Health. I'm going to pull up some slides here real quick. All right. And as Leroy mentioned, great segue. I'm here to share a little bit about cross-program collaboration with our colleagues at the Office of AIDS, and also how we're aligning some of our work with the Integrated Strategic Plan. So the California Department of Public Health, STD Control Branch, and Office of AIDS are collaborating to take an integrated approach and align our work with the Integrated Strategic Plan in a number of areas. Two that I'd like to highlight today are screening for syphilis, HIV, and Hep C in emergency departments, and the development of the syphilis and congenital syphilis outbreak grant funding. So firstly, our work to expand syphilis, HIV, and Hep C screening in emergency departments, or EDs, as you see it here in the center of the visual on the slide. I want to share a little bit of background on why we're focusing on EDs in general, which aligns with how the Strategic Integrated Plan is organized. So on this side, we've included the Healthy People 2020 social determinants of health. And I mean, as is evidenced by the plan structure, I mean, social determinants of health provide important context when thinking about factors associated with STIs, along with many other health outcomes. Each of these overarching categories includes many specific determinants, some of which come into play when thinking about how a preventable disease outcome can occur, and illustrates why emergency departments are such critical places for people who are most at risk for STIs and HIV, and thus why it's important to meet folks where they're at and screen in the ED setting. And I just also want to note that social determinants are just a piece of the picture. Racism impacts sexual and reproductive health outcomes on multiple levels throughout policies, practices, interpersonal interactions, and it has that reciprocal relationship with social determinants of health. So with that grounding in mind and sort of why emergency departments are such a priority, or one of our priorities, I wanted to share a little bit about how we expanded our work to provide technical assistance to emergency departments and local health jurisdictions on syphilis screening in emergency departments to also include HIV and Hep C. So we developed several technical assistance materials listed here. You see a slide set, like an introductory slide set and a resource guide. Initially, these were created specific to syphilis. However, in partnership with our colleagues at the Office of AIDS, thinking about the Integrated Strategic Plan, and also in conversations with emergency departments, we learned that a lot of the implementation considerations were similar for HIV, Hep C, and syphilis. So we've since taken this endemic and integrated approach to our technical assistance and materials. We've also launched a monthly community of practice for emergency departments. It's really meant to serve as an informal space where emergency department providers can chat with other providers about best practices, barriers and potential solutions that they're experiencing, and ways that emergency departments can partner with their local health jurisdiction on this work. And so this is a space for emergency departments that have already implemented the work, that are wanting to do it, really anywhere in the spectrum of implementation. And these conversations cover implementation considerations for syphilis, HIV, and Hep C. And we're also providing ongoing individualized technical assistance to emergency departments or local health jurisdictions upon request, pulling in syphilis, HIV, and Hep C subject matter expertise. Additionally, in September of 2022, the California Department of Public Health received $15 million in new state funding for a one-time grant program to strengthen testing for infectious disease agents in hospital emergency departments, including but not limited to HIV, hepatitis C, and syphilis. And these grants were intended to cover screening and navigation services to access treatment and prevention in high volume, mid volume, and lower volume emergency departments in both urban and rural areas. We are working very closely with our colleagues in the Office of AIDS on this, and we're still working out the details on how those funds will be made available. But several ideas to expand and build out more robust and integrated technical assistance support have come up as ideas on community listening sessions that we've hosted. So that's all being sort of part of what we're working through right now. Now I want to switch gears and share a little bit about how we grounded funding in the integrated plan with the Syphilis and Congenital Syphilis Outbreak Grant funding, or SOS grant for short. The final fiscal year 22-23 budget included $9 million for local health jurisdictions and $1 million for the California Department of Public Health. The funded local health jurisdictions are listed here: Fresno, Kern, Los Angeles, Orange, San Bernardino, San Diego, San Francisco, and San Joaquin counties. The funding focus is on innovative and impactful syphilis and congenital syphilis prevention and control, and with a focus on disproportionately impacted populations as determined by local epidemiology. And I can share that these populations, some of the examples that were included, align with the communities that are most affected by HIV, Hep C, and our HIV outlined in the integrated plan. So to develop the scope of work for that SOS grant, we met with local health jurisdiction and community stakeholders to identify key activities that should be considered for the focus of the funds. And then they were organized to align with the strategic plan. This is the first time in our sort of development of the scope of work that we took those social determinants of health buckets in the ranging the scope of work and tried to build around that. We ensured that the grant centered around racial equity throughout, requiring grantees to describe how activities in each part include a component specific to addressing racial equities. So at a high level, so there's the first part, which is part one, health access for all. This includes things like syphilis testing, treatment, and other healthcare focuses on syphilis. Syphilis, such as like doxy-PEP, is a possibility to interrupt ongoing syphilis transmission and prevent adverse outcomes. Linkages to HIV PrEP and HIV care, as well as linkages to prenatal, preconception, or family planning care. Those things were also included to prevent unintended pregnancies in people who do not want to become pregnant, and to prevent adverse outcomes for pregnant people, including congenital syphilis and perinatal HIV. In part 2, supportive services, housing, mental health, and substance use. This focuses on wraparound services identified as priorities for syphilis and congenital syphilis prevention, including possible partnership with contingency management programs. And in part 3, core surveillance and disease intervention focuses on some of our core public health functions that may not be met by existing local, state, or federal funding, and that's considered an optional use of the funds. So as I mentioned, there's a number of ways that we are collaborating with the Office of AIDS and trying to ground our work in the Integrated Strategic Plan. A few other things I'll just mention briefly is that we are coordinating our efforts to expand access to HIV and STI home self-collection testing with local health jurisdictions. We have also for some time coordinated our work around congenital syphilis and perinatal HIV collaboration, in particular, coordinated stakeholder engagement, presentations, internal work group coordination, and also coordinating and collaborating around internal and external racial and health equity work, trying to integrate that in the programs internally within our programs, and also in the external facing products that we are rolling out. And with that, I will stop sharing. Happy to take any questions or thoughts or additions from folks when the time comes. Thank you.
Wonderful. Well, thank you so much, Leroy and Ashley. We're seeing some appreciation for both of you here in the chat. We're going to move forward with our next presentation, and then we'll take a couple of questions for this first section of our agenda. After that, again, to participants on the line, feel free to continue to enter your questions directly in that Q&A function on your Zoom control panel as you have them. And so next we'll hear from Sara Duran, who is the Senior Consultant with Vicente Consulting. Welcome.
Thank you so much. Good morning, everyone. Very happy to be here today. Let me share screen. Okay. Hope that worked.
That's great.
So I'm very happy to be here today to talk a little bit about implementing the implementation blueprint. It's too many implementation, the word. But really the blueprint is meant as the companion to the Integrated Statewide Strategic Plan. And we're going to talk a little bit about what implementing this blueprint is really going to look like over the next year and some of the work that we're going to be doing to help get us there. So specifically, I'm going to provide an overview of some of the technical assistance opportunities that are upcoming in 2023, including launch activities, blueprint workshops, and in-depth support that we will be providing. So taking a quick look back at our process and progress thus far, which Leroy did a really good job of overviewing, I'm going to just briefly talk about this. This work really initiated a number of years ago as we started to plan and work towards the new strategic plan. The development of the Integrated Statewide Strategic Plan was an undertaking that took many months of thoughtful conversation, creative out-of-the-box thinking, and a whole lot of boundary pushing. The plan acknowledges the root causes of HIV, HCV, and STI as a syndemic and works to address those root causes. It approaches the work from a social determinants of health lens and recognizes that ending the epidemics requires partnerships with those throughout the syndemics fields, but also non-traditional partners that are not usually invited to the table. As Leroy mentioned in the blueprint, we're going to see a whole lot of those at the statewide level, but also recognizing that that has to happen at all levels, at both local, statewide, and beyond. The plan highlights and enhances existing public health efforts and activities that have contributed to successful outcomes and supports reframing our current work to transform the system and meet the needs of the community. Last year, we took this conversation on the road, and we got to meet many of you in person, as well as virtually, and worked with several counties representing urban and rural settings, Northern, Southern, and Central California, and beyond. We met with folks that work in the field, some non-traditional partners and consumers, folks with lived experience, and other stakeholders to discuss what the strategic plan should really look like within implementation. And we developed a blueprint for starting the work in each of the social determinants of health and within the 30 strategies in the strategic plan. This year, there are several ways in which we are going to be sharing the blueprint and working with local health jurisdictions and Part A partners through ending the HIV epidemic work that we are also involved in general meetings such as this, and also directly with jurisdiction leaders to support implementation efforts. Facenti Consulting will work with CDPH to coordinate a mini pre-recorded presentation for general statewide kickoff that's going to include how the blueprint works, what needs to be done, and what to expect with upcoming activities. In a few months, we're also developing and releasing a brief commercial video announcing the strategic plan, highlighting the blueprint, and sharing accomplishments thus far, which is a really fun way to ensure that this momentous milestone is being shared throughout the state. In addition, Facenti Consulting will work with various Ryan White Part A and co-authoring counties to coordinate launch parties. These are going to be focused on the local narrative and in really a celebration of accomplishments that have happened at the local level. Facenti Consulting will be designing and coordinating virtual workshops to help county leaders and co-authoring groups address plan implementation for their local areas. Workshops will include technical assistance on how to customize the blueprint, align local efforts with the strategic plan and ending the epidemic activities, prioritization and feasibility exercises, how to communicate the blueprint and the work that's being done, and community mapping for collaboration and forming collaborations. We're also developing and establishing a technical assistance request portal. Really fun, we can call it TARP. This will be utilized to request technical assistance. It will provide access to a full menu of technical assistance options and formats. The full menu is still under development, and you all can expect to hear more as the portal comes online. We're hoping that that will happen in the next couple of months. The portal is going to be used to request technical assistance, which is going to be tailored based on a low threshold assessment survey within the portal. TA will be provided through standard virtual platforms, phone calls, email, a whole host of different opportunities, and are provided to all counties upon request. We're also excited that concurrently, Facenti Consulting is going to be working with CDPH to provide implementation support for the strategic plan blueprint at the state level. At the county level, in-person meetings focused on landscape review and customized support will be offered to jurisdictions who require additional support. And this additional support is going to be, like I said, in person, and is really intended to be an additional layer of support above and beyond technical assistance. The support will be inclusive of a site visit to understand the county landscape, a brainstorm convening with local stakeholders, and establishment of concrete action steps, including future technical assistance needs and support to implement the blueprint. And lastly, Facenti will also support local health jurisdictions to finalize their local plans, both for their use and in preparation for sharing with CDPH if they choose to do that. That's it. My contact information is here, along with the contact information for the lead on this project, who is Lázara Paz Gonzalez, and our principal, Shelly Facenti. We'd be happy to provide any further information that you may be wondering about in terms of as you prepare for the implementation blueprint and modifying that to the needs of your county. So please don't hesitate to reach out. And thank you so much for having the opportunity to share this information.
Wonderful. Well, thank you so much, Sara. For everyone on the line with us, this concludes the first portion of our agenda this morning, our overview and process update. So we will take a question or two now if you have any burning questions for our first few presenters. I did see a question in the Q&A come in asking, how does the Ending the Epidemics plan relate to the integrated plan? So I wonder, Leroy, do you want to maybe kick us off on responding to that question?
Sure. So one of the ways that we've integrated is, first of all, by just referencing the body of work that is present within the EHE plan in the strategic plan. So what we submitted to HRSA HAB and the CDC actually cites our EHE work. The plan periods of influence actually overlap each other through 2025 and through 2026. Some of the focus populations are exactly the same, and some of them are different. I think our integrated plan has a more extensive list of focus populations. And the concept of social determinants of health work is all through our Ending the Epidemics work, as well as the strategic plan. So I think it's actually almost impossible, if you're approaching HIV, STI, and hepatitis C work well these days, to not actually have some type of social determinants of health lens in mind, but integrated testing. And then also, we also see some of the interventions that are present in the EHE plan that are referenced as specific strategies in the strategic plan. So things like self-testing, which we've already begun to implement across the state, by expanding or quick self-testing in every jurisdiction throughout California, and other interventions like street medicine, where we're taking and assisting some of our EHE counties develop a better understanding of how to implement a more rich primary care model on the street, focused on people experiencing houselessness, homelessness. And you'll see that in EHE plans as well as the strat plan. And so we are looking forward to the strategic plan, invigorating some of our efforts and leveraging more resources towards it. We're excited that some of our strategy partners, like the Department of Health Services, have made things like street medicine a reimbursable activity now, so that local health plans can allow that as something that that local entities can get reimbursed for. And as an engine that funds this activity, we're thinking that will expand as well. And our partnership with the Keck School of Medicine to develop a collaborative for anybody that's interested in street medicine also kind of overlap populations that are present in both EHE and the strat plan. With that, I'll stop there, but there are other things. We expect that more of this will be developed over the next year. More overlap, more leveraging will happen as a result of us rolling out the implementation blueprint and doing more local planning, as Sara has described.
Great, thank you. We also had a question both in the Q&A and a few questions from registration about measurement, and whether kind of measurement of activities will stay consistent, or if there are any new kind of plans related to measuring the success of the integrated strategic plan. Any comments on that?
So we noted that we have to have a place to begin. So our integrated plan actually begins with a lot of traditional indicators. We had 12 main indicators that were part of our original integrated plan, and those have rolled over into this plan and that is a beginning. And so we have done a crosswalk of each of our traditional surveillance indicators over into our activities, and so we've kept it at the 30 strategy level. We know and are working with all of our epi and data people to have a more developed set of indicators to begin. So they're taking things like our data that's available through Leo, for example, and seeing what indicators actually might be most relevant to follow as we begin the rollout of this process. But we also have suggested that part of our rollout of the implementation blueprint will be conversations with you about indicators that you might know of and want to use locally, and we will also take any recommendations from those. And I'm excited to hear the CHRP presentation today too, because also we have experts that are the engine of evaluation and research that are already thinking about how we can more in a better way, actually take a look at and monitor social determinants of health types of work. So I'll let my colleagues also.
Yeah, Ashley and Sara, do you have any other comments about measurement of the plan? Or, specific to what you're working on, any measurement or evaluation work that you're anticipating?
I can just add, when you frame it that way, I think, the emergency department screening work, for example, evaluation is a critical component of that. And so we have been working to develop evaluation questions, metrics, and measures, really trying to embed racial and health equity in those as well, as much as we can. And so there is a robust evaluation plan behind that work. And I would say a number of the other initiatives, including I just had a conversation this morning about our home self-collection, STI testing, and what is the future evaluation, which we'll be collaborating with Leroy and his team on. So it's definitely a key. I don't have specific metrics to share here, but that is definitely something that we are thinking about and wanting to make sure that we can share back sort of the outcomes and other evaluation process evaluation components for this work that we're doing to be able to support it.
Yeah, and I think Leroy actually said wonderfully everything that I had in mind, but I do want to add too that from the Facenti Consulting side, the folks that are working on the implementation blueprint and working with CDPH and the counties on that are the same folks that are also working on the EHE work, also supporting CDPH and the counties in that work. And part of what that does is it allows us to kind of really be able to bridge some of the kind of going back a little bit to the previous question, be able to bridge and integrate some of the conversations, as well as being able to, from the evaluation standpoint, kind of see some of the gaps and be able to really help in terms of bringing those forward and talking through some of the evaluation conversations that we're having on both sides of this conversation, really.
Wonderful. Well, thank you all so much. We are going to take a brief 5-minute break now. Since we have an extended 2-hour session this morning, we want to give folks a moment to stretch or, get some water, take a moment for yourself. And we'll be back right at 10:54 a.m. to start with our next section. Thank you all so much. All right, welcome back, everyone. I hope you had a nice little instrumental R&B break and got some water and had a moment to yourself. So we're excited to move into the second part of our session today. We're going to have a series of 10-minute panel presentations from 4 fantastic partners across the state regarding their engagement and approaches to aligning their work with the Integrated Strategic Plan. And we're going to begin with Ryan Clary with the End the Epidemics Coalition. Welcome, Ryan.
Thank you very much. You can see my slides and hear me?
Yep, looks good.
Excellent.
Sounds good.
All right. Well, thank you very much. And really, Elena, thank you very much for having me and having End the Epidemic present today. Last year, I came on and talked about the coalition and the advocacy work and successes and approach of the coalition, and really happy to be back to talk about the partnership and synergy between the coalition and the strategic plan. I want to acknowledge that there are End the Epidemic members and leaders on the line today, particularly Phil Curtis from APLA Health, who is the founder of the coalition. So, please do chime in on anything I'm speaking about to flesh out the presentation. I have had the honor of being involved with the coalition almost since the beginning, about 5 years. The coalition turns 5 next month, and an advocacy coalition lasting for 5 years is a pretty big deal and pretty successful. Just want to put our mission up here. So just to be clear, the End the Epidemic, and I know the names of various coalitions and projects can get confusing. We all kind of gravitate towards ending the epidemic or End the Epidemic. But we are an advocacy coalition. It's not a programmatic coalition. What our role is to secure funding and policies and leadership, focus at the state level to move forward goals to end HIV, viral hepatitis, STI, and overdose epidemics in California. So as I'll talk about, we work on epidemics, a couple of epidemics beyond the strategic plan. We also have a strong racial justice component and a stated commitment to center our work in racial justice and addressing systemic racism. So where our focus on the systemic has been, and this is, I heard, Leroy talked about kind of ETE having some influence on the state plan. I would say it's more kind of laying the groundwork. hopefully, and then now working in partnership around the idea of ending these epidemics in the state, which we know we can do. The coalition was founded with a syndemic philosophy. It started really with an in-person meeting to ask the question, should a coalition be formed to address, at the time, HIV, hepatitis C, and STIs together? It was a resounding yes, and enthusiastic, and really understanding the need to start looking at ending the siloed approach and being a lot more integrated, especially understanding the overlap of the epidemics and the need to educate state officials and decision makers around that. So the initial advocacy of the group was to urge, actually at the time it was candidate Newsom, and then when he was inaugurated, working with Governor Newsom to do what has happened, but really to take the lead as a governor to develop and prioritize an end the epidemics plan, obviously working with community and all of the right stakeholders on an integrated plan. And that was sort of the first action of the coalition. The first success was a sign-on letter that we put together with more than 150 organizations around the state signing on for this approach and representing HIV, viral hepatitis, healthcare, STI, civil rights groups around the country who believe in this approach, and then leaders like Phil had meetings with the administration, did not result in being in the governor's top priorities in the early years, but important to have those meetings to educate state leaders and, hopefully, helping to influence this process of CDPH having an integrated plan. And then, and the epidemic was able to secure and continues to have some success around getting funding for all of these epidemics, HIV, Hep C, STIs. Now, a couple of years ago, we expanded to address Hep B and overdose, and we were able to secure some Hep B funding a couple of years ago. So ETE has been very involved with the plan and with supporting the plan. Some leaders in the coalition participated in the state strategic plan work group, which of course were stakeholders and people with lived experience, people on the front lines, people representing impacted communities, having some meaningful input into the state plan. And here are some of the folks from the coalition who participated. Dr. Demetria Burns is formerly of World, but all of these are leaders and continue to be leaders in other roles, and only represented both the AIDS Foundation and the California Hepatitis Alliance. We had a presentation on one of our monthly calls where Facenti Consulting came on and presented the plan. I think we were one of the first coalitions who got to receive that kind of presentation, which was great, and it was a great way for coalition members to learn about the plan, find out about opportunities to provide input, and to learn in more detail. So we have our large listserv that we're able to circulate the plan for some input and dissemination. We promoted the town hall meetings, and we continue to have regular updates on our calls. So Leroy is on almost all End the Epidemics calls, which has been fantastic, and is able to update us each month on what is going on with the plan. So there is quite a bit of synergy, which is great because I think everybody knows there really needs to be strong partnership among stakeholders and particularly between government and public health officials and community advocates to move forward any plan. We know that from the National HIV/AIDS Strategy. We know the new Hepatitis C Elimination Plan, national plan that will be released in the next couple of months, and the state plan. For these plans to be implemented well, it has to be a partnership of all stakeholders and a recognition of one another's roles. And in this case, community's role in this is to advocate for the resources and the policies that are necessary to implement the plan. So the state develops the plan. State officials do not do advocacy. They don't go in and meet with legislators and ask for the funding proposals for these epidemics. That's what community does, and public health provides us with the information, the technical assistance, etc., to be able to do that advocacy. And so, like I said, having that partnership and understanding our roles is really critical. It is great that we are both, we are both approaching this from a syndemic approach. You know, I read through the plan again today just to refresh my memory, and there is so much overlap, which is fantastic, between the plan and our approach. And that's everything from centering racial justice and equity, addressing in a meaningful way the impact of systemic racism, really looking at stigma, which is at the heart of our work, and it's at the heart of our work with the epidemics that we've added on, hepatitis B and overdose and drug use, health of people who use drugs. I really love this this phrase in the state plan around access to healthcare and resources to stay healthy. That you have to look at all the social determinants of health. You have to look at the broader environment in which people at risk and living with the epidemic are dealing with in their lives, which is everything, you know, housing and food insecurity and all of those issues that we try to now look at in our work. And then it's really critical that we are both prioritizing harm reduction and the health of people who use drugs. You know, people who use drugs are at great risk for the epidemic that we are working on. So we had our first strategy meeting in several years in November of last year, and that happened after the release of the plan. So a lot of the discussions were informed by the plan, which was great. And we were able to get 80 stakeholders from around the state to convene in Los Angeles. We have a new program. We have a fellowship program in End the Epidemic. So we have about 25 advocates, new advocates, primarily from around the state, many representing impacted communities and people with lived experience coming, and most of them came to LA to provide, you know, really new insights to the discussions, and obviously, hopefully will become new leaders to talk about the gaps and the needs in addressing these epidemics, and to identify some priorities that we can then go and look at developing our budget proposal. So you'll see a lot of these priorities are listed in the state plan. And so clearly a lot of synergy now that we are developing or have developed our 2023 policy priorities very much in line with the plan. Just want to talk about, so the budget proposal has been developed, and it was developed based on those priorities. So I just want to run down it a little quickly so you see what the coalition is asking for from the state. I'll start by saying, I think we all know the state is in a not great fiscal climate with a significant budget deficit projected, and that makes it very difficult to ask for new funding and increased funding for programs. And a lot of the work is about protecting existing funding. That is not stopping the coalition for asking for some of what is needed, because why have an End the Epidemic plan if there isn't going to be sufficient resources to implement the strategy? And so the three priorities in the proposal are saving really the California Harm Reduction Initiative, vital services for people who use drugs around the state at risk really for losing staff and programs shutting down due to insufficient funding. So asking for $61 million to save that program, maintain staff and services, asking for funding for hepatitis C, given how little funding there is out there for linkage and services programs, with at least half of the money going to community-based services, and increasing money for STI. I think we all know the crises really in the state around STIs and sexual health. And I'll just close with some of our resources, our website. If you'd like to join us, please do. You can email me or click that link. I'll put a few links in the chat if that's all right, that link to our budget proposal and how to join us. And then you can also follow us on social media. So thank you again for letting me be a part of this. And I want to close by saying it's an absolute coalition. So without all of the members bringing to the table what they are able to with capacity and resources and bringing their expertise and insight, that is why the coalition has been so successful.
Fantastic. Thank you so much, Ryan. And please feel free to put those links right in the chat. Again, for everyone on the line, we are recording this session and we will share the recording and slides with everyone afterwards. So if you're wanting to access any of the links that are shown on the slides, you will have those as a resource after the session. I'm going to now introduce our next presenter, who is Rodri Deers-Davis, Director of the California HIV/AIDS Research Program. Welcome, Rodri.
Thanks, everyone. Can you hear me?
Yes.
All right, let me share my screen. Did it work?
Looks great.
Great. Hi, everybody. Good morning. My name is Rodri Deers-Davis. I am the director of the California HIV/AIDS Research Program. And I would like to spend the next 10 minutes presenting on the role that CHRA plays in supporting the Office of AIDS and operationalizing the Ending the Epidemic strategy and draft implementation blueprint. I'm going to start with a little bit, hold on. There it is. I'm going to start with a little bit of background about what CHRP is. We were established about 40 years ago in 1983, and we are based on unrestricted state general funds. We used to be a line item in the governor's budget, but we have since had our funding moved over to the state general fund and administered through the University of California Office of the President. As you can see, the majority of our money, about $7.5 million a year, actually goes down to fund grantees to do the research and evaluation work throughout the state. We try to keep our administrative costs fairly low. Overall, since '83, we've funded had about $400 million that we've distributed to fund over 2,000 research and program evaluation projects at both UC, non-UC institutions, health departments, CBOs, clinics, and several foundations. None of this happens in a vacuum. We work very collaboratively with multiple partners, including the Office of AIDS, but we do have an independent advisory council. We talk to our grantees, advocates, and community partners, and we do get strong support from state legislatures and the Office of AIDS to support this work. Our mission is to support our principal investigators as they go forward and conduct their research throughout the state to help with epidemic control of HIV and other syndemic conditions. We have several strategic directions. I will say our strategic directions do align with the Office of AIDS epidemic control goals, and our projects focus on issues of syndemics and social determinants of health, and make sure those perspectives are included in the projects that we fund. Unique to this agency is our ability to focus on efforts that are fairly complex sometimes, or on research projects and evaluations that are often seen as too risky or novel through other traditional funding agencies such as the NIH. This gives us a lot more flexibility than other traditional government-led grant funding agencies on what we can support throughout the state of California. I would say at our core, we have sort of three pillars of research priorities, which are reflected in our current portfolios that we fund. So to start with, our basic biomedical portfolio primarily focuses on 2-year laboratory-based pilot projects. We mainly fund early investigator awards. These are persons who are postdoctoral researchers or principal investigators who do not currently have a long tradition of getting funding from the NIH. So they're fairly new. Currently, we have 17 investigations that we're funding across 2 of our portfolios. I will say that we did a recent internal outcomes evaluation that revealed that the majority of these grantees do go on to get their research supported by other government-funded agencies in the future, and kind of use CHRP as almost like a seed money. Our next bucket or pillar is our implementation science portfolio, which focuses on HIV prevention and care projects with the overall goal of supporting novel program development and evaluations. these awards tend to be about 4 years in length and are primarily collaborative in nature, meaning that institutions often have to partner with other institutions to get funding for the work. So a UC institution will partner with a local government or a clinic or a community-based organization. Currently, we have 9 investigations across 3 initiatives that we're currently funding. And the last is our policy research, which is funded through both UC and non-UC institutions, supporting novel policy analysis and research, as well as advocacy to support initiatives such as the Ending the Epidemic strategies throughout the state. I'd like to spend the next couple slides giving some kind of concrete examples of projects that we're currently supporting and how they align with sort of the framework that we've been discussing here today. First, I'd like to talk about our California HIV/AIDS policy research centers. So these have been primarily at the forefront of supporting and developing the Ending the Epidemic strategies and implementation blueprint that we've been discussing. We helped host the first working group meetings for the Ending the Epidemic strategy back in 2018. We helped organize multiple meetings with stakeholders across the state over the next several years. We also initiated the community consensus statement that currently has about 150 signatories that is basically requesting or sort of pushing the governor and other state officials to continue to fund the Ending the Epidemic strategies. And we have continued collaboration through administrative and other support for the coalition that can be found on the CHPRC's website. I encourage you all to go there and take a look at it to see the important work that they've been doing. The next project is under what we would consider our implementation science pillar through our what's called the One Step Ahead initiative. I'd like to highlight some work by Dr. Nina Herrera, who is a joint appointment at both UCLA and Charles Drew Medical Center. Her current project investigates the effects of a mobile app called GeoPass in supporting enhanced engagement with HIV prevention and healthcare services for men who have sex with men and transgendered women who have a history of substance use and who experienced recent incarceration in Los Angeles County. This project's hope is to demonstrate that such a novel engagement with this vulnerable population can help keep persons safe and facilitate access to important prevention services during a difficult transition point in their lives. As you can see, the project supports multiple strategies outlined in the blueprint across many of the categories of interest, including workforce development strategies, data collection strategies for minority populations, collaboration with partnerships, as well as novel service delivery and stigma-free strategies that the state is spearheading. The next initiative is part of a new initiative that has just recently been funded this year under implementation science called the Community Collaborative Initiative. We funded 5 projects overall throughout the state. These projects specifically were meant to be collaborative in nature, so agencies had to collaborate with government and UC and or community-based organizations to get funded, and it was focused and the projects had to be focused on a disease endemics model. A project I'd like to highlight is sponsored by Dr. Albert Liu and Natalie Wilson, both of the San Francisco Department of Public Health and the AIDS Project of the East Bay. It's called Project Hope. And it is going to be testing a novel mobile unit focused on HIV and STI prevention services for African-American living in Alameda County who are experiencing homelessness. This is intended to be kind of a one-stop shop mobile clinic that is able to coordinate services supporting HIV, substance use, and mental health treatment for patients through one of 18 collaborating partners who are supporting this endeavor locally. Some of these services will be directly on site and some will be facilitated through warm handoff approach to support through the supporting agencies. I will also say that this project supports multiple framework strategies specifically related to the Housing First initiatives, mental health and substance use strategies, economic justice, and the stigma-free strategies. And we feel these collaboratives this one and then the other 4 that we are funding will go a long way to providing new and novel information about how some of these strategies can be operationalized and realized in the real world with real people who are in need. And finally, I'd like to leave you all with a quote that my predecessor, Dr. Andrew Forsythe, used in many of his presentations about the importance of local control and local initiatives. But I would like to also leave with an important point that, CHRP considers ourselves an important partner with the Office of AIDS, and our funding directly supports efforts to operationalize the Ending the Epidemic strategies within the state. We also see ourselves as a very important incubator of novel ideas and approaches that can not only help the state achieve its epidemic control goals, but can also be implemented at national and/or global settings where appropriate. Thank you very much.
Wonderful. Well, thank you so much, Rodri. Really appreciate your presentation. It's also just exciting to see, particularly, the implementation science work you're doing there. Here at CHIPTS, we're also working on several NIH-funded EHE implementation research projects, and it's just exciting to see that synergy there across different implementation research efforts to end the HIV epidemic. So now we're going to move to our 2 county panel presentations. We're going to start with Patrick Loza, Chief of the HIV, STD, and Hepatitis Branch for San Diego County. Thanks for joining us, Patrick.
Thank you so much. Let me share my screen here and hopefully everyone will be able to see it. Alrighty. Well, thank you all so much for inviting me here this morning. I'm happy to talk about some of the amazing work we're doing relative to ending the HIV epidemic here in San Diego County. And I want to start by making sure that I properly acknowledge our HIV planning group here and the amazing team here at the HIV, STD, and Hepatitis Branch, along with our community. It's been a long partnership. And we have seen some real results. So really excited to talk about this. I do want to note first that our journey with this actually began back in 2014. Some community members had approached the County of San Diego's Board of Supervisors with the question of, gosh, with improvements in treatment, with PrEP, what is the County of San Diego doing about HIV and how are we addressing this? And we formed a task force that met for about 6 months. We reviewed research, we reviewed epidemiological data, we took testimony from our communities. And at the end of that process, we realized that we had all the medical tools we needed to end the HIV epidemic. We just needed to think differently about how to deploy them. And we came up with the Board of Supervisors, came up with the title of Getting to Zero. We operationalized that into 5 pillars, which we are still using even with ending the HIV epidemic because there's remarkable overlap. The first 3 are test, treat, and prevent. Testing meaning how we deploy testing across the County of San Diego to identify everyone living with HIV so they can be linked to treatment and everyone vulnerable to HIV acquisition so we can link them to prevention resources. Treatment focused partly on persons living with HIV, ensuring that every person living with HIV has access to treatment without regard to their ability to pay. That is true in San Diego County today, and we're very proud that there are no waiting lists. And then prevent really talked about how we deploy prevention resources, particularly PrEP, in different communities to improve uptake of that. So that I think is something everyone's doing. There are 2 other pillars that I continue to hold on to because I think they're really important. The 4th pillar for our strategy is to engage our communities, to really ensure that persons living with HIV, persons vulnerable to HIV, have a voice in what we do. We really how do we set up systems so that we can hear from them over and over again to make sure that we're doing it right and to identify those places where we're not doing it right and think differently about them. And then finally, improve, which is the importance of quality improvement measures when we're looking at programs, particularly new programs that aren't working the way that they're supposed to. how do we use well-established, long-established tools for improving those? And I bring up improve, and I'll let it go in a minute, but I just want to mention that when we look at the very audacious goals of the National HIV/AIDS Strategy, 95% viral suppression, 95% identification, that requires near perfect performance nearly all of the time. And so these quality improvement strategies, I think, are going to be really crucial to our efforts as we proceed. So thinking about that, from that, we implemented a lot of activities, really did a huge focus on racial inequity, and identified 3 groups in the County of San Diego whose health outcomes were statistically significantly below that of other groups. And that included our Black community, particularly our Black, gay, bisexual, and other men who have sex with men, our Hispanic, gay, bisexual, and other men who have sex with men, and our transgender communities. And so we received funding from HRSA back in 2019 for building capacity for HIV elimination. And our project was to do formal community engagement with those 3 groups, really wanting to understand what works and some of the challenges that we are seeing. And what came out of this report, I think, really mirrors what we're seeing in the statewide strategic plan. We received direction that we really need to think differently about how we addressed system and, in particular, medical mistrust, particularly among our BIPOC communities, and also think about low health information and how we deliver health information in low health information communities. We were directed to really think about beefing up our community outreach activities and bringing more of our community members into our process. We heard this was being conducted right at the beginning of COVID, so we heard a lot about the need for basic support, particularly around virtual program participation, but just also hearing about the housing crisis and how expensive it is to live in San Diego County, and how all of those issues are really impacting people's abilities to prioritize their health and well-being. We heard recommendations about improving our HIV planning group. In particular, we heard about addressing whole person wellness, which is a feature of our programs, thinking about how someone living with HIV, when they show up to their medical appointment, they might not necessarily want to have a mental health appointment on a different day, and a case management appointment at a different location at a different day. How do we think about holistically the needs of our clients and create systems that wrap around those needs so the clients can do a lot less work in accessing the services they need? We heard a lot in that community engagement work about improving our health outcomes, particularly in our Black and Hispanic communities. And then we finally heard about reducing burdens for service access. What can we do to make accessing services much easier? What can we do to reduce any unnecessary paperwork requirements or burdens on those services? So really, I hope you all are hearing a lot of our statewide strategic plan in this, because there's really enormous overlap. What we've done with this, with some of our EHE funding, is we now have leadership development in place. The goal of this program is to ensure that persons with lived experience, persons vulnerable to HIV, have the ability to learn about what leadership is, so they can participate in the HIV planning group, so they could also join boards of directors of our nonprofit organizations and provide the really critical voice of someone with lived experience in how organizations are run. We are also funding more community engagement. Right now, we are focusing on women and youth and young adults. Later on this year, I believe we'll be doing some community engagement efforts with our Native American and Indigenous populations. We are funding re-engagement and care, so that if we have someone in any of our funded HIV medical providers who does not show for a medical appointment, they actually are funding physicians to contact that person and see about getting them back into care very quickly. And then we have finally deployed HIV prevention services for persons who inject drugs. And just want to note that it wasn't until January of 2021 that we were actually able to do syringe service programs, that our County Board of Supervisors finally removed a prohibition on our engagement with syringe service programs. And so I want to give huge thank you to all of the people who've been working very hard in making that change here in the County of San Diego. But we have now deployed funding to community-based organization for this work, and the County of San Diego will also be operating our own syringe services program to be deployed in the next 90 days. So we have a couple more services that are coming up. One is low barrier medical care, which is really drop-in medical care for people who have not been successful in traditional models of providing care for people with HIV. We are hopefully any day now, we'll be awarding a contract for prevention services for our transgender community based upon some of the input that we got during that community engagement process. Peer-based mobile PrEP delivery, really recruiting members of our populations of focus, particularly Black and Hispanic men who can be advocates for PrEP, who can represent PrEP, but who can also talk to their peers about PrEP. We're also hopefully deploying in the next 90 days a Getting to Zero mobile phone application, which will provide people with an easy way to download all the resources that are available here in the County of San Diego. And then finally, routine HIV testing implementation grants. So working with some of our nonprofit healthcare providers who would like to implement routine testing, for instance, routine testing in emergency departments or primary care settings, but requires some seed funding for that systems change. So lots of activities coming up over the next couple of months. And then finally, just wanted to mention there are three populations that we will be doing additional work with that I don't think really have been adequately addressed so far, but I know that they're on the minds of public health people all across the United States. One population is aging. Just want to note the Glasgow Manifesto and really the importance of ensuring that people who living with HIV who are in their 50s, 60s, 70s, and 80s, that we actually have a service delivery system that is responsive to their needs. I know that this is a major concern of our local HIV planning group, so we're going to be engaging in planning work on this. Also want to mention that they're really thinking about intersectionality in the needs of our disabled populations living with or vulnerable to HIV, and how some of the tools that we use don't work particularly well for disabled people and really need to think through those. Our local HIV planning group has done a lot of work in changing service standards around this and providing more specific direction to my office about what is required to really create systems of care that enable all of our clients. And then finally, medical advocacy. And this goes to a lot of issues that I brought up, in particular medical mistrust, but recognizing that we're not going to address medical mistrust with a 15-minute or 30-minute or 60-minute intervention. This is going to be a decades-long process of undoing a lot of the harm that has been done to our Black and Hispanic and gender non-conforming communities. It's just really going to require a lot of work, and medical advocacy is designed to provide these clients with support, including support during medical visits, so that our clients really are getting are really being heard and really able to advocate for what they need. So I know that this has been kind of it's just sort of a buffet of different things, but I appreciate everyone's time and attention, and I will cede the floor at this time. Thank you.
Wonderful. Thank you so much, Patrick. Great presentation. You see some thank yous in the chat as well. We're now going to move to our final presentation of the morning, and then we'll open it up for some panel discussion and Q&A. So I'm delighted to introduce our final panelist, Thomas Noble with the San Francisco Department of Public Health. Welcome, Thomas.
Thank you. I was just nervous if people could see how many windows I had open when I was screen sharing. Can folks hear me okay? I'm
Yep.
just not used to a
Looks good,
headset.
sounds good. You're all
Sweet.
good.
We doing okay on time?
Yep.
Awesome. So Patrick, that was a great presentation. It was kind of nice to hear another county's perspective. I feel like we all walk around kind of saying ETE, but we're all saying different things. So we're all using the same terminology, and kind of the diversity of the experience is so different. It's kind of hard for us to kind of wrap our minds around it. Whoever asked the question about measurements earlier, I was like, leaned into that one because I'm like, yeah, what are we all going to look at? With regards to making sure that we are try to get as consistent as possible, but at the same time, tailor services locally for folks. So my name is Thomas Noble. I work at the Department of Public Health in San Francisco. I use they, them pronouns, and excited to be here. All right, so just a little bit of a quick background. I've got 10 slides total. So, and I generally speak like I am an auctioneer, so I can go through those 10 slides relatively quickly. But our epidemic in the city, and specifically around HIV, is just our rates were dropping so significantly, specifically among men who had sex with men over the last. So we're really happy to kind of celebrate that win. But at the same time, you can kind of note the populations underneath although the numbers have always traditionally been small, they still remain current. So using our ETE funds, we decided to address that and take that on in a meaningful way. And part of the way that we're doing that is working with the populations that were represented in that slide, specifically African Americans, Latinos, trans women, people who use drugs, people experiencing homelessness, people with incarceration experience, youth, and young adults, and the aging population as well. So those were, so you can kind of feel that we're starting to do more of a nuanced energy around identifying the populations that are at greatest risk, and then just kind of acknowledging that the more significant thing is the de-siloing experience of not just taking on HIV alone, but combining it with Hep C and STI, and also including overdose prevention work. So we're kind of creating two different significant buckets with regards to people. Drug user health and sexual health are kind of those larger buckets, and we've gotten that feedback for years that community wanted services to look that way. And with the ETE funds, we're excited that we can kind of lean into that. And so with that de-siloing experience and kind of taking things on from a cross-cutting perspective, we're really trying to look at, you know, the issues that are impacting people's acquisition of various diseases and the quality of their life. And so we want to get to the root cause. But it's really quite challenging. I appreciate what Patrick said about you're not going to address medical mistrust in 15 minutes. So we're not going to take on racism, homophobia, housing, ableism, and sexism, and all the other things. But at least I feel like what I'm proud of in San Francisco that we've been doing is we've been giving names to those things and talking about them actively and openly, so that we can actually start to get a handle on what they look like. Then the next step hopefully would be to address them. But communication is challenging around issues that are really charged for folks. So, another way to basically say that is just kind of providing more wraparound services for individuals. So, and making sure that people's core needs are met. So our HIV, Hep C, STI, and overdose funding, we're wanting to make sure that we're including mental health, food access, and really kind of pushing out more expansive Maslow's hierarchy of need kind of things that need to be addressed in order for people who might have multiple things going on to take care of themselves, either sexually or around their substance use. And then just acknowledging intersectionality. So the idea of identity can be really quite complex with regards to, you know, does somebody want to walk through the services that represents their sexuality, their substance use, their mental health, their sexuality. And so making sure that we have access points that people can feel comfortable walking through the door, regardless of which part of their identity they would like to be seen as while accessing those particular services. Some examples of this is basically we're doing a lot of work on workforce development. I think COVID gave us a real opportunity to kind of shake things up significantly, and also identify the fact that the concept of lived experience is something that we now are starting to value in a significant way, either around substance use or race or sexuality. And so it's fascinating to our counselor training, for example, or HIV, Hep C, STI counselor certification process. A couple trainings ago, we had a couple individuals who managed to complete the 5-day training who were unhoused, had backpacks on and everything, brought it into the training space, and pretty impressed that we were able to create a learning environment that was supported somebody to be able to do that. So we're really focusing on workforce development, and as that builds out, we'll hopefully have, it'll be, a lot of it will be online, so people throughout the state or even the nation will have access to those resources. Street medicine, I think, is something that folks are familiar with regards to just meeting people where they're at. I know people kind of think San Francisco is small, but sometimes, you know, just going 3 blocks can be quite a challenge for an individual, especially if everything's going to be stolen. If they walk those 3 blocks, or sometimes just having a pet as well is a barrier for somebody actually being able to go into a clinic. We funded small capacity building programs, which are kind of $50,000 grants. So instead of traditionally giving money to the larger organizations, we thought we'd put out some seed money with this experience to diversify and reach certain populations. We have a promotores model on that, a couple that are addressing African-American needs, some that are addressing people who are unhoused. Good sex campaign and home testing, kind of the concept of people being able to access screening from the comfort of their own home with a sexual positive messaging. All right, and then in status neutral component, so we've been working with our partners within the department to make sure that we can, wherever we can actually put out funds that can address both people who are living with HIV and people who are at risk for HIV, Hep C, and STIs. And the concept of the HCV and the STI kind of allows us to lean into that in a more meaningful way. This is kind of just a significant visual with regards to the community groups that are on the left, Getting to Zero, and Hep C, Happen, FOG, BAHI. These are all community organizations or community activist groups that currently exist, our planning council as well, but they don't all tie together. I feel like one of our most significant themes with regards to our ETE work has been communication and coordination. So we have a lot going on, but they often don't kind of coordinate, and just my particular role is to help solve that, to tell you the truth. And it definitely is a challenge to try to figure out how do we pull together so many resources in a way that ultimately will be better for the clients, so they don't have to go to multiple spaces in order to access services. So the activity on the right is basically some of our solutions to making that happen. We're in a good spot, so we're kind of a big, small city and really excited about where we're going, but it still is, there's just so much good, it's a little bit overwhelming at the same time. And then just these are those organizations that I just mentioned, and then future potential. So if we can actually organize the network that we currently have, we want to kind of build out to address more of those wraparound services. And this is just a list of a lot of what those might look like. And that is my last slide. So thank you.
Great. Thank you so much, Thomas. Wonderful presentation. We are now going to move into our panel discussion and Q&A. So I'd like to invite all of our panelists to join us on screen again for a little bit of panel discussion. Thank you all. I see you turning your cameras on. All right. Great. So we are going to start with a few questions that came in during registration, but we'd love to hear additional questions from the participants on the line with us today. So if you do have further questions, feel free to continue entering them in the Q&A function on your Zoom control panel. If there are any that we can't get to today, I'm going to ask our very kind panelists to help me follow up on those additional questions after the session, but we'll get to as many as we can while we're on the line. So the most common questions that we received through registration were all about how implementation of this plan will be centering marginalized, disproportionately impacted communities. And so all of you, I think, touched on this at least a little bit in your individual presentations, but I did want to ask this question more specifically as part of the panel discussion, since it, I think it's so important and it's of great importance to our participants. So what are some of the key ways each of your programs, each of your efforts are centering marginalized, disproportionately impacted communities in your activities? Leroy, do you want to kind of start us off and then we can round robin?
Sure. Well, referencing the Ending the Epidemics work, there's a mandate that connects some of the funding that we actually allocate to, as part of implementing our plans, to connecting with community engagement. So, and that actually means meaningfully connecting to individuals that are named in the plan as focus populations. And our, the challenge, of course, is that our focus populations are actually individuals that may not do as well in standard prevention care and surveillance. And so we've done a variety of things to actually connect to substantially to individuals in places where they're at, rather than actually bringing them into and expecting them to actually connect with us. We have, there's a variety of strategies across all of the jurisdictions, but we've done e-surveys. We've used social network types of strategies of actually getting to various constituencies across different jurisdictions. We've actually gone out and created some forums in service deserts in different counties. We have had town halls. We've done a variety of things, and actually nothing's working perfectly, obviously, but I think that we really rely on the kindness of strangers, right? Like all of our folks that are doing similar things, we invite each other to each other's forums, and we're hoping to do better. But one of the things actually I'm particularly proud of is that when the counties are turning around and taking a previous weakness and actually funding an organization that has real and authentic connections to community, like trans persons, or working with the Black African American community in another jurisdiction, for example. I'll just cite that when capacity doesn't exist within the health department, then it's best to work with those organizations and individuals that have that capacity. What else have we been doing? I'll stop there, and I'll let, I was just kicking the ball off, but we're going to continue to do that. I'll just cite that in our plan, our strategic plan, that there is a strategy of nothing without us, nothing about us without us. And so we have specific activities actually outlined in our implementation blueprint that talk about just that. And so add to that, make that better. But that is a very important part of our plan, and it won't be successful unless we actually take that whole stigma-free section and that strategy in particular and make it. And today is actually non-criminalization of HIV Awareness Day, right? So stigma is actually killing us, and the only way that we're going to actually address stigma significantly is connecting to all populations, particularly those that are affected and most affected by HIV in all our communities, including myself.
Thank you, Leroy. Ryan, do you want to comment a little bit about how the ETE Coalition is centering marginalized communities?
Sure. So as a coalition primarily of organizations that we are, although anyone's welcome to come on and join our listserv, we really work with the organizations who are members who are really serving and representing marginalized communities, vulnerable populations, and working to get input and feedback as we develop and engagement around our budget proposals in a meaningful way. So, not just trying to kind of guess what organization members would like to see our budget proposals, but actually engaging in the meaningful conversations, which I kind of went over a little bit, the strategy meeting we had in November, and that all involves making sure there's funding to get people there, providing as much meaningful opportunities as possible so that our budget proposals to the best of our ability, and like Leroy said, not perfect, but doing the best we can to get that input and more than input, engagement in developing the actual proposal. And then our fellowship program, I think, has really helped with that. Like I said, 25 new advocates from impacted communities engaging and giving that input.
Wonderful. Thanks, Ryan. Patrick and Thomas, can you speak a little bit more to what you're each doing kind of at the county level to center marginalized communities? Patrick, maybe we can start with you.
Sure, thanks. Two things. I mentioned earlier our ongoing community engagement activities that are part of our Getting to Zero initiative and really talking to different communities. but that's part one, is getting input, like understanding what's working, what's not working. Part two is actually doing something about it. How do we actually implement these changes? How do we think about them from a systems perspective, right? You know, and I just to go off topic really quickly for a second, but when we talk about systemic issues, we don't address systemic issues by creating a different program. We also have to address what's wrong in the system and how do we fix what's actually going on in the system. I also want to say this, like, I think training is incredibly important. I appreciate that particularly anti-racism training is part of our strategic plan. I just want to note that you can't train your way out of a racist system, that you actually have to address the components in the system that are racist or lead to racist outcomes first. And so talking to our communities about what's not working is the first step. Like what is not working? So we hear about medical mistrust. Then it's about, well, how do we address this with our communities? We're going to try some things. We're going to co-design some interventions. We're going to try them out. We're going to see how they work, and then we're going to do the work to try to make them work better. So that's the place that we're in right now. So thank you.
Thank you. Such important comments about really addressing that system level, that system level, and we're hearing some claps. We're getting some claps and other comments to that point in the chat. Thanks, Patrick. Thomas, how about for you?
Yeah, it's such a broad question. It's hard to answer, but I feel like the thing that kind of comes, I'm more of a checkers player than a chess player, I tell people. So it's kind of the nuts and bolts pieces that kind of work for me. And I feel like I'm actually a representation of just workforce development. So I started out as a volunteer helping people through the dying process, and when I was 22, and that just turned into doing volunteer HIV testing, and I'm a gay, mixed race, dyslexic man. So making sure that the workforce is reflective, and I think we've leaned into that really significantly hard in the last 10 years, specifically around people using substances. So making sure that there's pathways and people's time is valued. Mentoringship programs that actually pay folks to attend trainings and spaces along those lines, making sure that the trainings are culturally appropriate. And it's fascinating when people go through the HIV test counselor training with me, they're just like, they're shocked that how much they enjoyed the experience, just due to the trauma of traditional education systems are so triggering and it's easy for people to tap into. So the lived experience of being dyslexic kind of really lends itself to understanding that kind of space. And so we're really, yeah, that's just like a scratch in the surface with regards to all we're doing to try to stand up individuals who are at highest risk for all of these diseases, and making sure that they're not just partners, but they're actually leadership. Stop there.
Yeah, thank you. Highlighting that, the workforce development and mentorship pieces, and also, that importance of representation in the field. Thank you for that, Thomas. Rodri, how about for you at CHRP?
Well, such things are generally linked to funding requirements, depending on the initiative or sort of pillar that I talked about that we're funding. Obviously, this isn't applicable for cellular-based laboratory research. But I will say that in all of our RFPs that we put out, people have to describe the populations in which their intervention or their project is targeted towards, and also why it's not targeted towards other ones themselves. So they have to kind of explain themselves a little bit. I will say, that Dr. Lewin Wilson's, project, the Community Collaborative, is a perfect example. They're focused very much on African-American homeless individuals in Alameda County. That doesn't mean that other minority populations aren't going to be part of that. But I will say the other community collaboratives are focusing on other key populations, and we take that into account when we look at a funding portfolio to make sure that maybe not every individual project is going to hit every population, but on balance, we're going to be offering broad-based support for diverse populations around the state as best we can.
Thank you so much. Ashley, how about for you at the SED Controller Branch? How are you all working to center marginalized, disproportionately impacted communities?
Yeah, in addition to the collaboration with Leroy and the Office of AIDS around the strategic plan, I think I mentioned a little bit at the end of my presentation some of the racial and health equity work that we've been embarking on internally and to standardize it in our external programs and policies. And I think At the core of that is the community engagement piece. And this is something that we're really working through right now. I think there's work to be done in this area for sure, but it is a focus. And it kind of links back to the question earlier about evaluation and metrics, which is something that folks on my team lead a lot of work for our program. To develop a good evaluation, you can't do that without the stakeholders for the program that are involved, and the community is a key stakeholder. So we are, the one small example is that we've developed an evaluation plan template. It's a tool, it's a small thing that we're using internally to help guide our evaluation and quality improvement projects that we're doing internally to support the programs that we roll out. And in it, we've standardized the inclusion of questions and data and metrics related to racial and health equity, and in it, stakeholder engagement. And I think there's some active work to determine, obviously tailored to what the program or the evaluation is, how we can engage with the community, leveraging some existing channels and exploring new ones as well. Some of those in partnership with Leroy and the team at the Office of AIDS, but others as well that we're exploring. So I think this is definitely something that is coming up in conversations in our work, and that we are trying to grow at it because it is so critical.
Great, thank you. And I love your kind of integration about the importance of, this issue as it relates to measurement and evaluation. Such an important thing for all of us to be thinking about. Sara, in your work helping to support the development and implementation of the plan at Facente, how have you all kind of worked to kind of elevate the needs of marginalized, disproportionately impacted communities in that work?
Yeah, thank you for that question and for the reframe. I think there's a couple of things that are coming to mind almost immediately. I think we said a lot last year that we used to categorize folks under this umbrella of hard to reach populations. But the reality is that they're not hard to reach. We just have not done a really good job of actually bridging that gap in public health. And so one of our jobs over the last couple of years and this year upcoming as well is to really start to try to do that, to do a little bit better around how we actually are working with the folks that we're here to serve. And so last year, we made a very concerted effort to go out and meet folks and not have meetings at public health departments or at the counties, but like, let's go to the library. Let's find places where we can actually engage a little bit more with the community. And in counties where it was really, really difficult, for example, we went up to Humboldt County and it was really difficult for folks from the mountain region to actually get to Eureka. So we made a pit stop and we took ourselves to Garberville and we had conversations there. So really trying as much as possible to meet folks where they're at and to engage in conversations. And for this upcoming year, part of our higher level of technical assistance will include site visits to actually in person have conversations with stakeholders, to really engage folks around these conversations, to say, how do we bridge that gap a little bit better? And as Patrick said, I think that was such a good highlight around how, we collect a lot of information in public health and then we just kind of sit on it. And then so how do we actually change and integrate the conversation that people are really telling us over and over and over again, this is what we need. And a lot of the times it's resource-based why we can't do it, but sometimes it's just because we're stuck in our ways. And so how do we kind of get out of that?
Yeah, thank you so much. I was on a call about a year ago where someone reframed hardly reached to hardly reached to hard to reach to hardly reached. Thank you. You all were nodding along with me. Hard to reach to hardly reached, which I thought was really important reframing that, it's not that folks are hard to reach, that it's really that they're hardly reached by the public health system, by existing programs. And it's really, on us to figure out how do we make sure that we're meeting the needs of folks who have not had adequate access to services. So I love what you kind of shared about that, Sara. We just have about 5 minutes left. I want to get to one more question, which is for the many partners on the line with us who work in a lot of different settings across the state. They wanted to know what resources will be available to them so that they can be a trusted messenger regarding this plan and ending the HIV epidemic efforts statewide and also locally. So I was thinking maybe we can kind of a little bit go in reverse order. Sarah, maybe starting with you, since you're helping to support development of some of these resources and the implementation blueprint. Can you talk a little bit about that? And then we can see if others have comments.
Yeah, so obviously, as Leroy said, the blueprint itself is going to be released very soon. And apart from the technical assistance that I kind of covered at the beginning of this call, through the TARP, we will have an assessment survey, and part of what will be a part of that will be the ability for us to categorize some of the technical assistance issues that are coming up, and then be able to provide additional resources that will be made available to the general public. So it'll be really important for counties and stakeholders to provide us with the information that we need in order to build up the resources moving forward. But we're really excited to have that kind of be the main hub of some of the technical assistance resource needs that are coming up in this year.
Thank you so much, Sarah. Any other comments from folks about resources currently available or in development to kind of help support some of your CBO partners and others on the ground working to help end the HIV epidemic?
Go ahead, Leroy.
No, I'm just going to say that we at the state Office of AIDS level and the SD Control Branch, I think we're always looking for ways to offer flexibility of funding to our local partners to be able to do some really innovative work. So I think that one of the great hallmarks of the EHE funding in general has been flexibility. We pass that along to locals, and we have seen some innovation at the local level. So we're going to continue to support that and also spread that around. So when we have a couple of forums where we have counties able to share information with each other, and we're going to continue to provide those types of forums so that we can spread this innovation out as much as we can as quickly as possible.
Thanks, Leroy. Thomas?
Yeah, I would just say, so we are a capacity builder, so CBA providing, and our stick is usually not to do a pre-boxed training. So it's more to do kind of a technical assistance that's tailored to whatever the particular need is. And just to be transparent within that, usually when we go in, the need that's been identified is actually not the need that needs to be met. So, and we all have blind spots, right? So, but I think it's change management, to tell you the truth. That's a huge piece of what we're talking about here. And we're asking our staff and our communities to change in a significant way. And HIV is changed in a significant way. So, and our whole world has with COVID as well. So just helping people kind of address that change. And I'm more than happy to help folks if they want to have that initial conversation about what that might look like. I think sometimes it just takes a different set of eyes and something to bounce off, and sometimes just to validate what you're experiencing to kind of help you step to that, to feel emboldened enough to go to leadership and say, look, this is what needs to happen. So I'll put that out there in the space. And I feel like from San Francisco, the healthier the state is, the healthier the city is. So.
Great. Thank you so much. We are right at noon now. So unfortunately, I wish we could stay on with all of you and talk a little longer, but it's been such a wonderful session this morning. It's great to have all of you on the line. Thank you so much to our fantastic panelists for sharing your amazing work and your insights with all of our participants today. Thank you to our amazing participants for your great engagement in the discussion and your great questions. As usual, please look out for a follow-up email from me with relevant information from the session and a link to the evaluation form. And again, the recording and slides will be posted by early next week on our EHE Regional Response webpage, and I'll share a link to that webpage in the follow-up email. So thank you all again so much, and we'll see you next time.
Take
Bye,
care.
everyone.
Thank you.